I wanted to move on and talk about treatments for psychotic disorders. There's been talk in the medical field about oral versus injectable medications. Can you talk a bit about the different types of treatments?
Well, for psychotic disorders, if we talk more about the schizophrenia family of illnesses, and there's more than one schizophrenia, I must say there are many schizophrenias, as I mentioned. There are at least three types of schizophrenias that we know of to date, and this is a gross simplification, but it's still useful clinically. We know that most people who have a schizophrenic type of disorder, about 3/4 of them in fact, will have what's called a hyperdopaminergic kind of illness. That is to say, there is too much dopamine activity in certain centers of the brain. And these people will respond quite well to the vast majority, essentially the entirety of antipsychotic medicines that we have available now, whether they be oral or by long-acting injection, because all of these antipsychotic medications will block dopamine and hence lower the levels of dopamine, and by that means help the person have fewer symptoms. Now, it doesn't work in every case perfectly, but it tends to work pretty well, particularly if people are treated early on in their illness, where one can achieve quite good results with symptom suppression and control of illness. There's another group of patients with the schizophrenic type of illness who will have a normodopaminergic or normal level of dopamine in their brain. So useless then to give them blockers of dopamine, which reduce dopamine because their levels of dopamine are the same as everybody else in the community. So there's one special medicine that seems to be useful in this particular situation, and this is called clozapine, which is a more heavy medicine to use. It's available only by mouth and requires blood test monitoring essentially continuously, but it is the only treatment for this kind of illness. There is a third group of schizophrenia, as we can say, or psychotic illnesses, because this can be extended to what we call very difficult to treat mood disorders like schizoaffective disorder, either depressed type or bipolar type, where there's residual and resistant psychotic symptoms. And this is also normodopaminergic, that is to say the levels of dopamine are normal, so it does not respond to dopamine blockers as such, and it only partially responds to medicines like clozapine. And about 50% of these patients will also improve with electroshock therapy. But it remains a very difficult group of patients to find a successful answer for. So that's really what guides us in terms of whether it's by mouth or by injection. Essentially, the choices of the injectable medicines are close to what we have in the oral medicines, but not entirely. So we have some oral medicines which are a little bit more friendly with respect to weight gain or blood sugar or cholesterol increases than we have available in the long-acting injectable medicines. The long-acting injectable medicines have their place particularly to ensure medication adherence. We know that many people will not take their medicines on a regular basis for a variety of reasons that have to do with lack of insight, which occurs in about roughly 50% of people with one of the schizophrenic illnesses, and this is not just a psychological lack of insight, it appears to be neurologically based. The insight part of your brain just doesn't seem to be functioning quite as well as in other instances. So people will not see the need to take medicine, even though everybody around sees the need. There are also, of course, existential reasons not to take medicine. I can't be sick, it's impossible, I'm too young, I'm too nice, and so on. There are side effect issues sometimes that one has to deal with. And sometimes there's magical thinking. If I don't take the medicine, that means I'm not sick. If I take it, it means I'm sick. I don't want to be sick, therefore I won't take the medicine. There's some other elaborations of that, but essentially one is confronting that. We know that when people relapse because of non-adherence to medicine, they will have, unfortunately, an increase in what we call pharmacoresistance. That is to say that medications which were very effective before lose their effectiveness over time. And we see this, unfortunately, all too commonly, that many patients are given oral medicines that they don't take or don't respond to, even if they do take them. And they should be put on to clozapine much more early. Or if they do have what we would call a hyperdopaminergic kind of illness, too much dopamine, they should be put on to a long-acting injectable medicine much more early than is the case now, just in order to ensure that the illness is treated and that further deterioration does not exist and that this pharmacoresistance does not exist, which plagues everybody in the course of the illness. One psychosocial intervention that is also very important in the clientele that does have a significant drug abuse or alcohol abuse problem is what we call motivational interviewing, to try and help the person realize that there is a problem, which would be the same kind of intervention for anybody with that sort of drug abuse or alcohol abuse problem, and to try and do a partnership with groups and organizations that do treat drug abuse. It's not true that we treat the drug abuse first and then we treat the problem. They are both treated at the same time.
There's a new injectable medication on the market. It's called Invega Trinza. Do you know much about that?
Yes, and Invega Trinza is medicine that's already available in Invega Sustenna. It's the same molecule. It's actually a metabolite of risperidone, which has been around since 1993, I believe, in Canada. And the Invega Trinza is a medication that is given by injection every 3 months instead of every month, essentially, or every 4 weeks for the Invega Sustenna. It has the same advantages and disadvantages that the Invega Sustenna has in people that do well with this kind of injection. It will be much less bother for them to take it every 3 months rather than every month, let's say. But there's not anything more special about it than that. There's a convenience element, but some disadvantages, of course, are that sometimes the dose needs to be higher and the interval may not be 3 months. It may have to be 2 months or something less. Or if the person has, unfortunately, a normodopaminergic kind of illness, that is to say, normal dopamine levels, giving a dopamine blocker like Invega will not do anything, so the person might not actually benefit from that kind of intervention.